Так. І
Yes.
у нас зараз буде час для
And now it's time for questions and answers.
попросити
I would like to ask you
на цьому курсі є психотерапевти,
about the
які
following.
не
Here in the
спеціалісти
audience, we have
в
psychotherapists
психотерапії,
who are not very familiar with TFP.
року ми
In the
проводили
last
курс
academic year,
ТФП, який
we
проводив
gave
Франк
a
Йоман,
TFP
але цього
course
року сьогодні
hosted
є
by Frank Yeomans. But here in
психотерапевти
this audience, we have therapists who did not attend that course last year. Could you tell us, in short, how TFP addresses patients with borderline personality disorder? What should be the focus? What would you recommend if you work with borderline patients using TFP? Also, I would like to say that we will do another TFP course, but not this year, next year, or maybe even later. Could you give us an overview, briefly, how TFP would address borderline patients?
Are you asking me to give you a summary of the technique of transference-focused psychotherapy? Okay. Okay. The objective of TFP is a resolution of the identity diffusion and normalization, therefore, of the total psychological functioning of the individual in the areas of work and profession, love and sex, social life and family and personal creativity. The treatment can be described as having strategies, techniques, and tactics. The strategies are to permit the development in the transference of the split internalized object relation of an idealized and a persecutory kind, to facilitate that the patient express fully his primitive split-off pathological object relations. And we analyze each of these as they get activated in the transference in terms of the dominant affect involved, the position of the self regarding that affect, and the position of the object. For example, enraged interaction between self and others in a sadistic enraged other, and suffering, fearful enraged self. And we want that fully expressed in the transference. We point out to the patient how he is expressing that with the role distribution between patient and therapist, so that the internalized object relationship is reproduced in the here and now between patient and therapist, directly, in that the patient takes the role of his self and projects his object onto the therapist, and also in reverse, in that the patient takes the role of the object and projects the self role on the therapist. And patients do this rotation all the time because the very fact they have the lack of an integrated self at the center around which then gets organized the representation of significant others. That patients don't have such a center, but oscillate between idealized and persecutory ones, makes it much easier that in each interaction, they really identify with both. When we internalize our conflicts with parents from birth on, what we internalized is not the image of the parents, loving or hateful, but the image of the relationship that we had. So that's an identification that is a dyadic unit constituted by a self representation and an object representation, and the affects linking them. And we want each of these significant ones show up in the transference, and the most important ones show up indeed, both persecutory and idealized ones. And with both persecutory and idealized ones, we help the patient to see how he's identified with both self and object, so that the patient who feels persecuted by a revengeful mother is identifying with self as victim of such a mother and the therapist as such a horrible mother. And 10 minutes after that, the patient acts as if he were that terrible mother and projects his helpless self onto the therapist. And we want the patient to fully accept the identification with both self and object in the persecutory relations and in the idealized relation, when everything seems super. It's the perfect mother relating to the perfect baby. We want the patient to be able to identify with self and other in both idealized and persecutory relation. So we don't try to tone that down. We try to let it flourish. Wild idealization and wild persecution. And once the patient tolerates that double identification with self and other in both the positive and negative affect roles, then and only then we start interpreting his keeping those idealized and persecutory relationships separate to avoid that the bad one destroy the good ones and he end up in a terrible world. We point to the fact that he's defensively trying to construct unrealistic ideal relationship to protect him from the destructive ones. So the interpretation at first are geared to familiarize himself with the unconscious identification with self and object of idealized and persecutory interactions, and then to interpret his defensive keeping separate his idealized and persecutory identifications. And in the process, we help him to achieve identity integration, an integrated sense of self, integrated sense of significant others are gradually developed. And when at the end of the process, the patient is able to have an integrated view of all his different mental states and acquire in the process a solid sense of self and meaningful view of significant others who are no longer split into idealized and persecutory ones. That is the strategy. The technique is the use of 4 psychoanalytic instruments. We use interpretation of unconscious relations activated in the sessions. We use transference analysis by analyzing all these internalized object relations that were directed toward the parents or came from the parents and are now expressed in the relation with the therapist. So we interpret unconscious meanings and then specifically how they affect the transference. Transference interpretation is interpretation of the split-off relationship the patient establishes with the therapist with the objective of fostering that integration. So general interpretation, which is non-specific, but permits us to get into an ideal point where we touch the insecurities of our patients and are able to resolve them in facilitating their identification with the unconscious dissociated aspects of their own personality. So interpretation, transference analysis, then we have technical neutrality and countertransference utilization. What is technical neutrality? It's not disgruntled indifference. It is a concerned objectivity by which the therapist helps the patient become aware of the object relation activated in the transference. The therapist helps the patient by transference interpretation to bring about that change. And technical neutrality means that the therapist is not contaminated by the idealized or the persecutory relationship. The therapist carefully stays out of any decision-making that will put him into the idealized or the persecutory stance. And this position as an outsider and a third exclusive one who interprets, that is transference analysis. And at the end, we utilize our emotional reaction to the patient, and they are very intense with these patients to better understand what they are doing to us. We analyze our countertransference without without signaling it, showing it explicitly. We are helping the patient see what's going on in transference by utilizing our countertransference to describe the total situation of what's going on in the session. So technical neutrality is a complement to transference interpretation in that one stays out from becoming part of the transference, but one is an outsider, analyzes it to show how the split between idealized and persecutory relationship is taking place in the transference and how they can be resolved. And countertransference utilization is utilizing the strong feelings that evolve in the therapist in doing this work, in that whenever the patient activates a certain transference by projective identification, he tends to induce the corresponding feelings of that particular object relationship in the therapist. So the therapist, in his countertransference, is the victim of the projection onto him of whatever it is, what the relationship that is activated signals. And the therapist will be using that countertransference without communicating it directly para hacer ver al paciente de cómo él mismo es parte de la situación que está analizando y cómo entenderla. So countertransference understanding permits the therapist see the role in which the patient is trying to cast him, and he used that to interpret that effort on the patient's part to cast him into that role. These are the four basic techniques: interpretation, transference analysis, technical neutrality, and countertransference utilization. There are a number of other techniques, but these are the four essential ones. And finally, tactics refers to specific ways in which we deal with a usual crisis in the treatment of borderline patients and in the treatment of all patients with borderline personality organization, not only borderline personality disorder. These are carefully enacted defensive and progressive processes that are helpful with particular circumstances that otherwise would make the treatment very difficult. I'm referring to the effects of the patient's projecting onto us his own internal conflicts and how that makes us feel as if we were the ones who have that conflict and are tempted to act on it. And that in turn permits us to help the chapters to really become aware of what's going on. Among those special tactics, we have tactics of dealing with development of psychotic regressions in the transference, intense aggressive affect storms, disruption of the treatment, suicidal temptations, and a number of other similar ways of approaching special situation. We probably have about 20 of such special mechanisms that include how to deal with antisocial behavior, with psychotic regression, complication of one kind or another, and how to deal with negative therapeutic reaction and acting out, how to use dream analysis and the analysis of reaction at the termination of treatment. All these are then tactics. The essential aspect are really the strategy and the techniques. The manual edited by Frank Yeomans with several others of us is, I think, a version that's 2 years old, the latest version of the treatment, because as we gain more experience, the treatment is changing and advancing in sophistication. That would be my summary of transference focused psychotherapy.
Дякуємо. І
Thank you. Now, Maria,
можливість
it's your
більше ніж 30 хвилин задати
time. We have a bit more than 30 minutes to ask the most important questions. Yes, thank you. Colleagues, I will remind you that you need to ask your questions in the chat. For this seminar, we have this opportunity to speak only in case you sent a written question and some comments are needed. So please write your questions. Dr. Kahnberg, first question is this. What was the longest and the shortest period that took a borderline patient to go to neurotic organization in your practice? Have you had situations when borderline patients could not transfer to neurotic level of organization?
In other words, are there cases where we fail in bringing about this change, where the treatment doesn't work? Is that what you're asking?
Так, і перше запитання, який найкоротший в руках?
Yes, and what period of time was needed for that in your experience? The shortest and the longest, from borderline to neurotic. So what was the shortest and the longest time that it took in your experience?
The treatment should last usually at least 18 months. Our experience is that's a time at which we can expect significant change in many cases. Sometimes it lasts several years. It's a long-term treatment. It's as intense as psychoanalysis, although it has a lower frequency of session. It is sufficient usually to have 2 sessions per week rather than 3 or 4 or 5 as psychoanalysis is practiced. So it's a long-term treatment and roughly effective between 60 and 70% of cases. There are patients who don't improve, and we have studied some of these factors, and they are not surprisingly cases in which the intense aggression and envy and hatred are such that the patient cannot accept the help that is being offered. There are cases where so much help is experienced by the patients as humiliating and generates envy and resentment, and they have to destroy it and can't accept to be helped. There are patients with profound masochistic tendencies who are oriented to suffer as a major purpose of life and may prove to be very difficult to treat. At the bottom, in all cases, there are elements of self-directed aggression directed against the treatment that we usually overcome, but sometimes don't. So there are cases in which, particularly with antisocial behavior, secondary gain of the symptoms, well, the degree of aggression and resentment goes beyond what the therapist is able to neutralize and overcome. That would be my response. And cases with wrong indications, of course, include those with low intellectual capability and some patients in whom there is a kind of a triumph in illness that they have gotten used to and they are not prepared to abandon. So for some cases, the triumph over the therapist is more important than improving their symptoms.
Дякую. Наступне запитання від
Thank you. Next question from Mark Raffel. I'm sorry if I'm mispronouncing your name. The question is this: do you think that complex PTSD is actually another name for BPD, or is it a separate disease, symptoms of which are similar to borderline personality disorder?
I don't know what's the question.
Повторю. Запитання від Марка Раффала. Чи
Mark
вважаєте ви,
Raffel asks, do you think that complex post-traumatic syndrome disorder is just another name for borderline personality disorder? Or is it a different disease, symptoms of which are similar to symptoms of BPD?
You mean complex post-traumatic stress disorder? I think that's a misnomer for a personality disorder in the etiology of which a traumatic situation has played an important role. Sometimes severe trauma is an etiological factor, but not part of the illness itself. That would be the case when after a post-traumatic stress disorder, the patient develops symptoms of personality disorder. It's a personality disorder with all the elements of personality disorder. And with quite a frequency in those cases, there were already indication of that personality disorders before the traumatic situation. As we look carefully at the case, we find out that there was already a particular predisposition in this regard on the part of the patient.
Дякую. Запитання від Людмила Коліснюк.
Question from Ludmila Kolesnyuk. It was asked in English.
Is it possible to work with patients with a borderline personality disorder using their not native language? How could it influence a treatment?
Didn't understand.
Я прийду на, можливо, це one second. Все ж таки прийду на українську
Okay,
мову.
I will read it in Ukrainian then. Can we work with patients who have borderline personality disorder not in their first language? How will that influence the treatment?
Patients who get treated in a language which is not their original one, as long as ordinary communication can be maintained, it can be done. Patient and therapists learn to complement whatever difficulties are in the language communication by clarifying what they want to say in an area for which they initially may not have found the right words. So as long as ordinary knowledge of the language needed for daily life situation is available, it can be done. If language is not enough for ordinary interactions, then not.
Дякую. Наступне запитання від Джена Даффі. Чи є якісь
Jenna Duffy asks, I will change the question slightly. Are there age limitations when you can start TFP? Is there a certain age when you can start TFP?
It can start in early childhood. We have experience in treating children from 4 to 6 years. Our Berlin group particularly is very good at that. We have patients in their 70s and 80s. So there is no age limit. There are periods that are more difficult to treat. Adolescents can present particular challenges. We may need modifications of technique. But by now we know them well, and it's integrated into the overall treatment schema.
Дякую. Наступне
Thank
запитання.
you. Next question is from Mark. Rafal, can you comment what are other psychotic symptoms that we often find in BPD? So paranoia, being suspicious, or a deficit of logical thinking, what Arietti called schizophrenic thinking.
Patients may develop psychotic reactions during the treatment. We differentiate patients who develop a psychotic reaction only in the transference. They develop psychotic transferences. One case. There are other patients who develop a full-fledged psychotic reorganization that shows outside the sessions, and we call that transference psychosis. And there are patients who activate a pre-existing illness or a latent illness in the transference. They may reactivate a paranoid psychosis or a schizophrenic illness or a major depression. in the treatment. So these are different cases that have to be treated differently. If the patient develops, if the patient reactivates a schizophrenic illness, then really that needs to be treated. That illness needs to be treated. Generally, we end treatment with TFP and shift them into treatment of psychosis. If the patient develops a transference psychosis, we first try to use the method that we call dealing with incompatible realities. If that doesn't work, then we end the treatment and give him a specific treatment for his psychotic illness. Usually, psychotic illness needs to be treated with a combination of psychopharmacological treatment and psychotherapy. And there are several modifications of that. But first, we try to use the method of incompatible realities. If the patient tells us something that he thinks we have done or that has happened, a patient thought that I had seen him on the street, walking on the opposite side of the street, and I had spat in a contemptuous way on the ground to indicate my depreciation of him. He was convinced that I'd done that. And that showed my hatred of him and my treating him in contemptuous way. May seem a small thing, but the patient was very angry, was convinced of that. And so once it, or another patient thought that I had forbidden all the nurses of the hospital to have sex with him. He thought that I've approached the entire nursing staff forbidding them to have sex with him. So what we do, first we find out that the patient really is convinced. I tell the patient, I know you are really convinced of that, and I accept that this is your conviction. Now, can you tolerate that what I think about that? And I tell the patient that I think that what you think is completely crazy and has nothing to do with my behavior or my thinking or whatever. Now, you can think that there may be two things going on. I may be lying. I know perfectly that I behaved the way you said I have, and I'm lying to you. And if you believe that, we have to study why would your psychotherapist, wanting to lie to you. We call this analyzing a psychopathic transference. Or I might tell the patient, if you think that I'm really honestly telling you what I think, then either I must be crazy in thinking different, or you must be crazy. And we have no witness. The only thing we can decide, there is a madness here in the room. We can't adjudicate it to him or to me. But what he can do is to study the content of the madness and see whether that adds to our understanding of the situation. And so then we analyze the meaning of that what is being attributed to me, and usually that reveals the underlying conflict. Is a very effective method. That's the method of incompatible realities that may resolve the problem. For example, the patient who thought that I had ordered all the nurses not to have a sexual affair with him. He got into this because he invited a nurse to have dinner with him at his home. And he had told her that he knew me. And the nurse refused having sex with him. She wanted to go home and went home. He got furious because he thought that I had forbidden her to have sex with him. And he generalized that and said I probably had forbidden to all the nurses to have sex with him, and came enraged to my office the next morning. Enraged because I'd forbidden nurses to have sex with him. And so I used this method. I told him I didn't do that. I would never do that. It seems to be completely crazy. But we have no witness, so we don't know whether he's crazy or I'm crazy. And I said the important issue was that a man in authority was interfering with the right of all other men of that circle to have the right to have sex with the nursing staff of the hospital. In other words, a man who used his authority to keep the other men at the castrated state. And this brought an immediate memory to the mind of my patient of his father, who was a doctor in a small town. One night, the hounds, the dogs were barking, and father got into a rage and cut the vocal cords of the dogs, and the patient, who was 7 years old, got into a panic. So he had a sense that he got into a similar panic when the nurse didn't want to go to bed with him. So we could understand that it was a traumatic experience that was being relived and could be resolved by this way of dealing with it. That's one example of a tactic that I mentioned earlier.
Дякую.
Thank you.
Ще одне запитання, наступне.
The next question. The question is, I apologize if I mispronounce, a question from Behzad Rostami Sani. Please explain the difference between neurotic and borderline projection. Between the projection on the borderline level of personality.
The difference between projection as an advanced defense mechanism and projective identification as a primitive one. Is that what you're asking? Okay.
Я думаю, да, єдине, що
I think so. I think that was the question, but even though the author sort of put it together, but maybe he wants to understand what is the difference between projective identification and...
The projection as an advanced defense is based upon repression. The patient attributes to somebody else something that's going on in the patient, but the patient is not aware of that. the patient is not aware that this is going on in him and attributes it to the other person. So it is repression, lack of awareness what's going on in him, complicated by the projection onto somebody else. That's the advanced form. The primitive form is projective identification, in which the patient attributes something that's going on in him to somebody else and behaves in ways that tend to induce that kind of behavior or thinking in the other person. The patient helps for this displacement of the self onto the other, while the patient still maintains empathy with what is being projected. The patient knows how it feels, what he now thinks the other one feels, and he's inducing into the other one that which is attributing him. And at the same time, the patient is trying to control the other so that the other doesn't act toward the patient under the impact of what is projected. So it's a complicated mechanism in which there is not only attribution, but a combination of induction, attribution, empathy with what is attributed, and effort at control of that which is projected. That it's a very powerful primitive mechanism.
Дякую. Наступне
Thank
запитання.
you. The next question from Dorina Lemma. Distinguished Dr. Kernberg, could you please comment? Should TFP be recommended to patients who definitely have bipolar personality disorder and definitely some other personality disorder, such as narcissistic personality disorders? Can TFP be affected in conjunction with the medicine, with medical pharmacology treatment?
Yes, there are cases where we combine it with medication. For example, with patients who have an intense characterologically based depression or a bipolar illness that can be treated on an outpatient basis. Or intense panic reaction that interferes with their functioning. Patients who have addictions or eating disorders may have to be treated simultaneously with TFP and by an expert on addiction or eating disorder.
Дякую.
Thank you. And this is the next question from Kiana Zibai. Apologize if I mispronounce the name. Can we see sexual fantasies and masturbation among married individuals in neurotic level?
I didn't understand the question. Can what happen?
Чи можуть бути одружені
Can
люди?
we have married people who are neurotically organized? Can
Yeah.
they have sexual fantasies and can they masturbate?
That is perfectly normal. We all have, we all build up what John Money called love maps, special scenarios that have particular erotic significance for us. And they permit to develops sexual excitement, intensify sexual excitement, intensify the pleasure with the excitement phase and the orgastic phase of intercourse. So there may be private fantasies, sometimes having no relation at all to the intercourse that the person is having at that moment, but that are part of that internal fantasy structure. So we are not only motivated sexually by our hormonal status. I mean, our hormonal status, levels of testosterone, for example, influence our sexual excitement. We are also more influenced than by hormonal influence by our internal developed specific sexual fantasies that are in a synthesis of our sexual impulses influenced by our conflicts and past experiences. And they get activated, and that is perfectly normal. They are very interesting because sometimes in patients with severe sexual inhibition, it is these masturbatory fantasies which open up the road to understanding what's the nature of the conflict that is interfering with their sexual life. So they are always interesting.
Дякую.
Thank you. And 2 minutes to go, but I will attempt to ask one more question. Alexei, may I? Okay. So this is the final question from Katerina Zakovaiko. Could you please describe in a greater detail how problems with creative self-realization work in borderline personality disorder? Katerina writes, as far as she understands, many highly talented people have BPD, but they manage to unleash their creative potential. This is the question.
I'm not sure I understood it, but should I explain in some detail the self-representation of borderline patient? What is it? I didn't understand the question.
Я думаю, Катерина, якщо ви
Well,
тут,
I think, Katerina, if you are here, Katerina Zakovaiko, if you're here at the front row, please feel free to unmute and speak about it. Are you here?
Зрозумів питання.
Alexei says, I understood the question. This was the question. So, as far as I understand it, the borderline patients have certain problems with sublimation capacities. And what we're seeing is that certain artists, musicians, poets, and writers maybe they have borderline personality disorder, especially where we know the details of their biographies. We can assume that there's some borderline quality in them. But at the same time, these people can create very important things in art, in music, in poetry, and in other fields of human life. So what do you think about it, Dr. Kernberg? How is that associated if the sublimation function is disturbed and possible masterpieces that can be created by borderline authors?
I think there may be efforts to sublimate some emotional needs by borderline patients. In some areas, they may be successful, but obviously it doesn't cover the entire problem, or they have other problems. It's hard to know. But the potential for advanced defensive operations such as sublimation, which is a normal way of dealing with impulse that is not permitted to fully express himself, is perfectly feasible. There are borderline patients who may maintain creativity in an area of literature or art or in their work that may have important compensating features. And there are certain psychotherapeutic treatments that are trying to foster that, what is called the resources of the patient, to become constructive. The German depth psychology, psychoanalytic psychotherapy by Rudolph uses this potential of patients, sublimatory potentials, and to develop them and stimulate them to develop their natural resources for being creative. So that's a definite possibility, that's open.
І, доктор Кемберг, саме останнє питання можна ще? На сьогодні останнє.
And the very last question, Dr. Kernberg, the last for today. May I?
Так, можна?
May I ask, Dr. Kernberg?
Yes.
The question about supervision by Irina Dichenko. How do we know that this relationship is real or fantasy, or one of the partner is in illusion? So again, this is about supervision. There's a patient, and you said that neither the patient nor her constant partners are not in a real relationship. So the question is about this. How do you know whether this relationship is real or imaginary? And what are the characteristics of the real relationship?
Are we talking about the relationship with the therapist or in the patient?
Ні,
No. Relationship with the partner from supervision. You said in supervision there was no real relationship. Hannah's patient didn't love her patient. She wanted to break up with him. He did not take it seriously. And you said this is a non-relationship. And that's where the question comes. How do you see it's a relationship or a non-relationship?
Well, love relationships have certain characteristics. And if the relationship of the patient fulfills those characteristics, then we think it's an authentic relationship. But if clearly the relationship does not, then there's something false about it. In the case that we saw today, the man says he loves her, wants to be with her, but he's not going to marry her. There's something false about the relationship. It's contradictory. So this is how we know. Usually the criteria are well known. If you love somebody, you want to be with that person. You want to be forever with that person. You are interested in that, you like that person. You are happy when you are with that person. You are interested in what that person thinks and feels and wants to do. And you feel good and happy when that person is happy. And you trust that person. You dare to let him or her know what's troubling you, what you have difficulty with, and hope to be helped and understood. And you trust that whatever that person will do or tell you will be done in good faith and will be of help. At least you will feel understood or accompanied. So if all of that fits together, it's a real relationship. But if you have a blatant contradiction, then you start questioning it. The patient whom we saw earlier clearly doesn't know what a love relationship is. By accepting a completely contradictory relation, which shows that this man really doesn't love her. He may be interested in a sexual relation, but once he's satisfied, he doesn't need her anymore.
Мгм. Я
Яке
так
сердечне питання наостанок.
Yeah, that was quite a question to end it all with. We should go back to our beloved ones. It's 10 p.m. here. Dr. Kernberg.
Ні, я кажу, яке душевне питання останнє про любов.
Yeah. The last question that was about love is a good one to finish it all with. We need to go and see the people who we love. They miss us. Dr. Kernberg, thank you so much for this wonderful seminar today. We started with borderline disorder. This is borderline pure. And then we will improve our knowledge about other types of personality disorders. We will talk about histrionic, dependent. And in December, we're going to speak about narcissistic disorder. Thank you for being with us, for your honesty, for your energy, and for being so passionate about teaching. This is always so nice. This is what we learn from you as well. Thank you.
Well, thank you very much. I appreciate that you find it useful. That makes me feel very good. It has been the purpose. I'm trying to convey to you as much as I can about what I know and what has been helpful. And I very much enjoy sharing what I've been able to discover and to learn with you, my colleagues, and looking forward to our future work together. And thank you for your efforts in translation. I appreciate that.
Ми дякуємо Ірині Насталовській та Марині
Yes,
Менциковській.
we're grateful to Irina Nastalovska and Marina Mintsikovska for interpretation effort. We had two more interpreters, Yana Gutsak and Alexandra Komarova. And we had quite a setting. You didn't notice how difficult it was, but it was hard to add another language. And I think we did it wonderfully. I'm so grateful to my team, the technical team, Alexander, Maria. Thank you for juggling the questions, selecting those that are the most interesting and sensible. That's a lot of work. And we're grateful to you, Alexei, as well. I'm reminding you that registration to Module 2 goes on, and you still have early registration prices until November the 1st, and we shall see each other in November then.
Okay, bye-bye.